Thank you very much. It's really an honor to be here. And we've heard a bit about adaptive designs. We've even heard a bit about the battle trial. So what I'll try to do in the next 20 minutes or so is talk a little bit about the trial, about lung cancer, and about lessons learned, and how we're using that information to move on in the future. The battle trial was designed around lung cancer, which is of course a major health problem around the world, with well over 1.3 million deaths worldwide. In the United States, we have about 160,000 a year. It is the number one cause of cancer death in men and women. We diagnose more prostate cancer because of screening, more breast cancer because of screening, and actually now in the United States we're beginning to screen for lung cancer as well, so perhaps we'll have an impact on the disease in that way. But clearly there's an urgent need for better therapy in the advanced setting, metastatic disease. It really is, for the most part, an incurable disease, except perhaps for some patients with EGFR mutations, and even there we know that resistance develops reasonably often. So the focus of our work has been on targeted therapy for lung cancer to find the right patient, the right drug, and put them together, as we've heard about throughout this conference. So the traditional approach in lung cancer, until not too long ago, was to break it up by histology, and that's still done to some extent. But really now in 2011, in the adenocarcinoma patients, we have actionable mutations that have been identified that can really have an impact on patient care. And of course, the two for which there are drugs available are the EGFR gene mutation and the ALK translocation, with crizotinib just becoming approved in the United States about a week and a half ago. And we've heard at this meeting, we heard from Dr. Thomas and others, certainly in squamous cell cancer, there is a great deal of research and hope now for other new targets which are driving specific clinical research programs. However, the bottom line is when you see a patient with advanced lung cancer in the clinic, for about 15 to 18% of them, you can use one of these new therapies perhaps to give them a drug or to put them on a trial. But really, what about the other 20%, the other 80%? And that's where a program like the Battle comes in. Now, these days for the non-squamous patients, many of them are getting a targeted therapy, bevacizumab. However, despite being available for almost 5 years now, there still are no molecular markers or predictive markers for that agent. For the adenocarcinoma patients, as I mentioned, EGFR and ALK, drugs available, MET amplification. Of course, crizotinib is a MET inhibitor. That's how it first went to the clinic. There are multiple MET inhibitors now in clinical trial, most of them in combination with EGFR inhibition. And of course, we've heard a bit about PI3 kinase, and Herceptin is still a possibility. And then for the squamous tumors, a number of clinical trials ongoing as well. Now for EGFR mutations, this story is of course quite historic, to the point now where almost every patient with lung cancer in the United States is, at least the thought is there, and we're trying to make it a practical reality, that patients will be tested for an EGFR mutation. And these tend to be either deletions in exon 19, point mutations in exon 21, and we now know from a number of trials, this being the IPASS trial, that if you have an EGFR mutation, even in the front line, and you get an EGFR inhibitor versus chemotherapy, the progression-free survival is much improved. And you also know that if you don't have a mutation and you get the EGFR inhibitor, you actually do worse. So it really is important not to use clinical characteristics anymore, but to use tissue and molecular genotyping to assort patients to the right trial. And the EML4 ALK story is equally powerful, though the story's much earlier. But I think the point here actually is that from the time that this was discovered to the time it went to clinic was only a period of 2 or 3 years, whereas the EGFR story, erlotinib and gefitinib went to clinical trial more than a decade ago. So it speaks to the fact that we are becoming more molecularly focused in our approach, and certainly this translocation, the results of Dr. Quack and colleagues showing that if you pick the right patient, nearly every patient has a response. I have an example of one on the next slide. Truly an example of a patient with metastatic disease who had failed multiple therapies, who gets this drug because they have the specific genetic alteration, and you see responses, improvement in quality of life. And the question, of course, will be how soon does resistance develop? And already some of that has been described. So that's a little bit of background about the hope of lung cancer. Some oncologists earlier today had said they're being depressed. I actually think that it's very positive that we are seeing that the work we're doing is translating into new agents for the patients. But the problem is in the natural history of lung cancer, at least until recently, it was very rare that we would actually get tissue that we could use. And even if we had tissue, this tissue was usually from stage 1 and 3 disease. It was from the early diagnosis of a patient, the first presentation of their lung cancer, So by the time we got the patients for our phase 1 trials, the refractory patients with lung cancer for phase 2 trials, we had very little tissue, and the tissue we had was not really relevant because it was tissue from before the patient had gotten platinum, before they'd had radiation. So the concept that we developed at MD Anderson, and this being myself, Ed Kim, Ki Hong, Ignacio Estuba, Jack Lee, and really a team of about 30 who I'll acknowledge at the end, we put together our heads and said, could we develop a program in real time where patients with advanced metastatic disease who came in, and what we could do is we could get a fresh tissue biopsy and get that biopsy and analyze it quick enough, within a week or two, because these patients all have median survivals of 3 to 5 months, could we then look at those results and use that information to treat the patient more effectively, but also learn so that the next patients could be treated even more effectively, and that, of course, is the adaptive design. So tumor biopsies became critical, and we really changed the culture of a 17-physician practice, where we went from running 10 to 12 different phase 2 trials and put all our efforts into one single trial, an issue I can discuss at the end, one trial in an academic practice. But we had one trial, we all worked together, we spoke with the patients, we developed a research nurse infrastructure, and that's the BATTLE trial. So BATTLE stood for and stands for Biomarker-Based Approaches of Targeted Therapy for Lung Cancer Elimination. We figured why not shoot high, elimination. It's a platform for integrated translational research with a number of clinical trials, as I'll show you, a novel adaptive design, and the opportunities exist for biomarker discovery. So even if we're completely wrong with our markers, and we heard from Sabine that you have to have good markers to make this work, and even if our drugs end up not making it, and some will, some won't, we have tissue in the bank. Fresh tissue, frozen tissue from 300 patients with annotated follow-up, which we can then take to some of the techniques we've heard about at this meeting, deep sequencing and other, for discovery. So that's always there, but the question is, can we help patients in real time? Can we develop markers for drugs for which there is no single mutation that tells you that that drug will work? And we had 3 hypotheses. We did base this on 3 very fundamental hypotheses: that real-time biopsies are possible to more accurately reflect aberrant signaling, and I already showed you that, a few examples. Matching targeted agents with abnormal pathways will improve disease control in lung cancer patients, and that 8-week disease control is acceptable as a surrogate endpoint. Now that's been discussed already by Dr. De Bono. We used 8 weeks, 2 months progression-free survival, lack of progression. The reason for that is if you're using an adaptive design where your algorithm is going to continue to upgrade with each patient, you need an endpoint that's rather quick. If we waited for overall survival, that would take too long. The other reason why we use progression-free survival in lung cancer is patients are getting many lines of therapy these days, 3rd, 4th, 5th, 6th line. And when you're looking for a predictive biomarker, if you use survival as the endpoint, I would contest that what might happen is your marker might not reflect the agent that you're testing, since it could be confounded. And it's very hard these days. In fact, the most recent 4 or 5 trials in refractory lung cancer have not shown a survival benefit, and one of the potential reasons for that is because of crossovers. So we decided to focus on the signaling pathways that we had the most expertise on in our group at MD Anderson at the time, either from our clinical experience or our laboratory experience. Of course, that included EGFR, and we had been very involved with the first trials of gefitinib and erlotinib. The anti-vascular agents, myself and John Haymack being very interested in this, having trained in Boston, and we were targeting VEGF. RAS and RAF, now we've heard a lot about that in lung cancer, adenocarcinoma. This is about 25 to 30% of the patients. It's sort of the major cause of unmet need in this disease. Really very few drugs. There have been many that have come forward, and few of that have passed the test to target these pathways. And RXR cyclin D1, this is of historic interest, the work of the late Ruben Lotan and Ki Hong looking at this pathway. So biomarker groups by molecular pathway, one thing we did in the BATTLE trial, again being our first iteration of this, is we got real biopsies and we analyzed them for 14 different markers. We did group the markers. And I'll show you this at the end. That might not have been the best thing to do. We did this for simplification. But if you have a group of markers, let's say your EGFR marker group includes the EGFR mutation and gene copy number, high polysomy or amplification, you're only as strong as your weakest marker. And at the time when we developed this trial, now about 6 years ago, there was some indication that gene copy number might be a very useful marker. It's not panned out as well as we had thought. Our second marker group was pretty straightforward, KRAS or BRAF mutations by direct sequencing. Our third group was VEGF expression. Now, this was immunochemistry, so subject to some variability as immunochemistry can be, but well quantitated by Dr. Westuba, our pathologist, looking at VEGF ligand expression as well as receptor expression. And our fourth group was RXR cyclin D1, and this was a bit of a mixture of this group in that we had RXR alpha, beta, and gamma in the tumor by immunochemistry. We had cyclin D1 immunochemistry, and we had FISH for amplification of cyclin D1. And all this was lumped into group 4, and then as you would have it, this group 5, where there were some patients, about 15 to 20%, for whom the tissue was not adequate. We were learning in this first trial of trying to obtain biopsies in all patients with this disease. So what was the eligibility for battle? It really, if you're developing a new trial, which we were, where we're trying to get the physicians to take the time from a busy clinic to talk to a patient about a biopsy, we wanted the denominator to be large. So we really made it so that all the agents were oral and that all the patients really had no limit on the prior therapy. Some patients had 5 or 6 prior therapies for their disease. And as many of you know, those patients actually tend to have ironically better performance status because perhaps they have a bit of a slower growing disease. But it was second plus line non-small cell lung cancer, a very heavily treated population. The patients had to have adequate performance status. Since I've moved to Yale and left MD Anderson, I now understand the good performance status patients we used to get in Houston, the ones that had to fly to Texas to get there. Most of the patients, they were performance status 1, a few performance status 2, and a few 0 patients on the trial. The patient had to have biopsy amenable disease. One thing that's very important, most of these biopsies were done by CT-guided procedures. Rather than just sending everyone off for a biopsy, we screened first. So when a patient came in, as part of the umbrella consent process, we actually sent the films to the radiologist, most cases electronically, and had him or her look at the films and tell us whether this was something that they felt they could, with reasonable safety, biopsy. And we did allow patients with stable brain metastases. These patients are often excluded from lung cancer trials, but about 20 to 25% of patients will have asymptomatic brain metastases at the time of diagnosis. So we included these patients after they'd been treated with radiation. And here's basically how the trial worked. And the design was one where we actually had 5 separate clinical trials through the IRB, really as one battle program. There was the front gate, an umbrella protocol, where the research nurse and the physician spoke to the patient, obtained consent, determined if the biopsy could be performed, and then once the patient was consented, in the first turnstile, we obtained that core biopsy. There was a 2-week window that we could obtain the core biopsy and have the 14 different markers needed for the adaptive randomization performed in our lab. Now, we did this trial 5 years ago. We did this work in a research lab. This was Dr. Ignacio Westuba's research lab. In the United States, you would say that's a non-CLIA research lab. As we've gone forward in future iterations of this, now the regulations have changed a bit in that these all would need to be done in a hospital-based lab, which is just something that you need to be aware of. If you're working with multiple markers, you need to convince your hospital lab to run those tests. But these were all done in the research lab. Many of these actually now are standard tests. And then we made the decision whether the patient should go on one of 4 different treatment arms, either erlotinib, an EGFR inhibitor, vandetanib, a dual EGFR VEGF receptor inhibitor, a much more potent VEGF receptor inhibitor, a combination of erlotinib and bexarotene, which had been piloted by Ethan Dimitrowski's group at Dartmouth to target the RXR patients, and sorafenib, which we felt would target RAF, but we also had some hypotheses from some laboratory work that it might target RAS-activated cells as well. We used an adaptive program. You've heard a bit about that. I'm going to explain to you a bit how that works. When you do adaptive randomization, your first patients are equally randomized because you have to develop what's called a prior probability. You have to learn how the markers correlate with activity of the different agents, in this case being 8-week disease control, 8-week lack of progression. And then once you learn, you become adaptive, and I'll show you that in a moment. So a lot's been said about Bayesian adaptive randomization. Now, I have an interesting story on this. About 3 years ago, I was asked by Marge Foti to be a preceptor in an AACR course in Sonoma Valley, California. And I had a group of 8 graduate students who were all statisticians, and they came up to me. I was with my wife and child at a cocktail party and said, "Dr. Herbst, you're from MD Anderson. You must be Bayesian." And I scratched my head. I looked at my wife. I said, "No, I'm actually from New York." And certainly at MD Anderson, with Don Berry and Jack Lee, there's a real focus on adaptive design. I'm trying to make the case that I think that this is really a useful method. It is really intensive as far as statistical labor. You have to have a good number of statisticians. At a center where you have 20 or 30 and you have someone dedicated to your group, it's really possible to do, and I think it's very helpful, but you really have to have that support, and you have to have the creative design to do it and the ability to do all the simulations, and we have that at MD Anderson. The idea would be that more patients are assigned to more effective therapies, and that's our goal as clinicians. We see a patient, we want to do what's best for them in real time. That's, of course, what we're doing with clinical trials. But wouldn't it be great if we could tell them, well, you're going to go on the arm that looks best for what you have based on the person who came before you, based on accumulating data and learning as we go. But again, as we heard earlier, you have to have good markers, and you have to have good treatment options. So this slide is meant to show adaptive randomizations. It's a little cartoon, and in a second, not yet, I'm going to ask the person in the booth to press the button. But basically, initially, patients went on each of the 4 arms equally. There was a 25% chance of them going onto each of the 4 arms. And what this simulation is about to show you, and it's just a simulation, it's not the real trial, and I've written it for 40 patients. You'll see after the first 40 patients who are going to be equally randomized to develop the prior probability, you'll then see that the patients start to be assorted to the arms in a more adaptive way. So you can see initially the patients will go on an adaptive trial in a completely equal way. And then as we learn, you can see the probabilities change. And these change based on the progression-free survival, the 8-week progression-free survival of the patients who came before them. They're not being completely randomized here, but they're being randomized in a skewed way so that more patients going in the arm that the hypotheses that the algorithm suggests will benefit. So this was our adaptive randomization. Every patient went to the statistician first. They then came back and told us which arm to put the patient on. So here's the way the battle trial worked. Registration 1 week, then 2 weeks to get the biopsy and biomarker analysis, the 8-week progression-free survival, the primary endpoint being disease control. What about tissue? You have to satisfy your pathologist. Our biopsies in this trial were all core needle biopsies. Those biopsies tend to give you, in many cases, more cells, but not always. The problem with a core needle biopsy, we learned, is if you do a core needle biopsy and radiographically you go into an area that looks like tumor, but it's necrotic or fibrotic, you actually might get far fewer cells than you might have gotten with a fine needle aspiration. Why didn't we do cytology on these patients? A matter of cost. We didn't want to have to send a sample to the routine pathology lab. In our Battle 2 trials, I'll show you, to try to increase efficiency, we actually have added in cytology so that we can be sure that we're in an area of good tumor. You can see most of the biopsies in the battle trial came from the lung, as you would expect in patients with metastatic disease, but we also biopsied from other sources, lymph node, liver, adrenal glands. The only one site that was really very poor was bone. As you would expect, once you decalcify a bone lesion, there isn't very much usable tumor left. Certainly if there's medullary tumor in the bone, that was useful. I'm just showing you that about 83% of the biopsies were adequate, either from squamous or adeno, but if you had a necrotic or a fibrotic area, these biopsies were not very useful. And we put these patients on the trial anyhow, because they'd already gone through the process, but in the analysis we took it into account. So here's just an example of this program, and again, the team at MD Anderson, Drs. Kim, Hong, myself leading the trial. You can see we began this in late 2004 and reported results in 2009. So even with all the resources and patients of MD Anderson, it took a while to get the trial through regulatory approvals, really 3 years to enroll 300 patients once we started the trial, with 255 patients randomized. There was some screen failures, patients who did not make it through all the tests or had poor performance status, and 244 evaluable patients. The biopsy procedure was well tolerated. The pneumothorax incidence was 11.5%. I think that's rather low compared to the historical literature. A patient might think otherwise, but we only had 1 grade 3 pneumothorax, only 1 patient in the whole series hospitalized overnight, and really the other drugs were well tolerated. They were all oral combinations with 90% compliance. And this was monitored by an external DSMB, which is something that MD Anderson does for all the trials that are adaptively designed. Someone externally should be keeping an eye on it. This slide is just showing that the 8-week disease control, with all its pitfalls, and Dr. DeBono made some good points, did correlate with overall survival. We hypothesized that before the trial started. We proved it with over 300 patients in the trial. For those patients who had disease control versus those that didn't, the median survival was 11.3 versus 7.5 months. So it did look like this was a good discriminator for the overall outcome of these patients. We did find one marker, our hypothesis, we would find at least one marker for each agent. Now the first, erlotinib, you might say, what's he showing us? We all know that EGFR mutation correlates with outcome for erlotinib. We didn't know that when we started this trial. That's how many years ago we started it. That's why these trials have to go a little faster, perhaps exporting them, as we heard from the last speaker. The next step is going to be, can other sites do this and send the samples in? But the EGFR mutation did correlate with outcome. Vandetanib high VEGFR2 expression improved results, and I've certainly been involved with several lung trials with vandetanib, and we're certainly looking at this in some data sets. John Haymack is looking at this now in large randomized trials to see if we can pull out a set that looks better. For the erlotinib bexarotene, high cyclin D1 expression and EGFR amplification by FISH both correlated with improved outcome. And here's an important lesson for sorafenib. If you had an EGFR mutation or high polysomy, you actually did worse. So the lesson here is you might actually do worse, not better, with one of these markers. So really it is important to understand the markers and identify them and use them correctly. This is actually very interesting. I mentioned KRAS, the elephant in the room. 25 to 30% of patients, they do poorly with pretty much all therapies, chemotherapy of course too. And you can see in patients who were KRAS mutated, my contention would be they did actually worse with erlotinib. So 22% disease control if they were KRAS mutated with erlotinib versus 37% versus the rest. Actually, some might say that all groups do pretty bad. We need to find a better marker for erlotinib in wild-type patients, and I'll show you we're working on that. But interestingly, with sorafenib didn't discriminate between RAS and non-RAS mutated patients. It had reasonable activity in both. And of course, sorafenib has multiple activities. One might call it a bit of a dirty kinase, but it did have 61% activity in RAS patients, where all the other agents combined was about 20%. So we're thinking there might be something there. So this is a hypothesis that's going on to the lab and being tested in the BATTLE-2 trial. Discovery, I mentioned we have all this tissue. Everyone wants our tissue right now. We are going to begin to use it for some of the discovery approaches such as sequencing. But what did we have built into the trial? Mostly mRNA profiling. So John Haymack presented these data at the AACR, and I don't have time to go into this in depth, but he developed signatures for EGFR in wild-type patients, so the non-mutant EGFR patients, who benefits, who doesn't, who's going to have stable disease, because very few of them will respond. For KRAS, this is in progress, EMT, and a 5-gene signature, wild-type erlotinib EGFR signature. That's what WE stands for. So just to show you the data that he presented at the meeting, so this 5-gene signature shown here, looking at disease-free survival, does appear to discriminate between those patients who had disease control versus those who didn't. And actually, if you look at this signature in the erlotinib arms, it can really tell you who's going to have disease control versus who isn't. And if you look at it in the sorafenib arm of the BATTLE trial, it doesn't discriminate at all. It also correlates not only with disease control, but with true progression-free survival, presence of the signature versus not. Now, of course, this needs to go on and be validated in large data sets in the next BATTLE trial, but this is an example of a signature for a gene. These are not the mutant patients who are going to respond, but the wild-type patients who might have some stable disease. Perhaps this can help us to differentiate that. Some of you might say we probably should just go find another drug. That's an alternative too. KRAS, very interesting, and this actually addresses some of the points that we heard from earlier speakers. What's going on with KRAS? Why does it work some places and not others? Well, we partnered with Garth Poas and Nathan Eiley, one of his graduate students, and they actually showed us that the KRAS mutations in lung cancer are different from the KRAS mutations you see in colon cancer. Of course, about 80% of lung cancer patients or more will have smoking-related disease. And actually, in these patients, cysteine changes in codon 12 tend to make up the majority of RAS mutations, whereas aspartate is much more common in colon cancer. Why is this important? We actually looked at our data for all treatments or with sorafenib, and we looked at the disease progression-free survival data for patients who had mutations in codon 12 to cysteine or valine or any other RAS mutation or wild-type RAS. And what you can see, it's those patients with the cysteine or valine changes shown in red in both graphs that tend to do the worst. So it might be that signaling is different depending on the specific RAS mutation you have. Now think about this. This is only 25% of the patients. It's still only a 300-patient trial. We're now breaking it up into different subtypes. We're not going to be powered in this trial to definitively say anything, but it certainly generates a reasonable hypothesis. And because we had the tissue, John Haymack could then do the gene array work and actually show that you can break down these patients into two groups, those who had the cysteine or variant and all other. So it does appear that signaling is different depending on the mutation you have. And again, my time is limited, but Nate, as part of his graduate thesis, a wonderful graduate student, actually has looked at some of the signaling and shows that when you have the cysteine mutations, you're actually not signaling through AKT, whereas in the other mutations or the wild type, it appears that you are, but instead the signaling appears to be going through RAL A and B. So it does appear that there's differential signaling pathways depending on the mutation, and of course that could have a very big impact on what we heard about, for example, from Dr. De Bono, and who might respond and who doesn't. And just tell you that the battle trial really was a good start. It showed us that we could get biopsies, we could use these biopsies, and we could develop markers from these different biopsies. And it really was a team effort, and I was very fortunate to be part of this team for 15 years, and now I'm building a new one in collaboration with this group at Yale. And just in the last 2 or 3 minutes, I'll tell you that we now have a Battle 2, and Battle 2 is attempting to use more specific targeted drugs. So after 5 years, the drugs have gotten a bit better, attack more novel targets, and use drug combinations, because we've heard that really the idea of combination targeted therapy is going to be essential. Selection and validation of novel predictive markers in real time. If you don't know the marker at the beginning of the trial, and you have to fix it for a period of 3 years, you might be putting yourself in a big hole. So the way we've developed Battle 2 is we're going to learn the markers in part 1, and then validate them in part 2. And we have all these collaborators, because what happened was we talked enough about Battle and we published on it a bit. Companies started to come to us. What a great opportunity as a clinical investigator, as you're writing your next grant. People came to us, including Steve Friend, and he came up to me about 3 years ago and said, can we do our next Battle trial with you? So we said, sure, but we're not just going to do any drug. We wanted to pick hypothesis-based combinations. So we actually were very interested in targeting MEK and AKT for the very reasons we already heard about, targeting RAS. So actually, Merck had the 2206, and they said, well, we have this sort of informal relationship with some other company. I can't tell you who it is, but they have an AKT inhibitor. Of course, we were already working with AZ as part of an institutional alliance. We already had preclinical data, so this became part of the Battle 2 trial. In Battle 2, we've also continued sorafenib and the EGFR inhibitor to validate some of the signatures. We already had preclinical data, as I mentioned, from Dr. Jack Roth, who had already been working through the AZ MD Anderson alliance with MEK-AKT combination, these very two drugs, and we already knew that we had activity in RAS-mutated tumors. And actually, this is the same slide we saw from Dr. De Bono. I got this from Dr. Tolscher, his collaborator. We already knew that in lung cancer, RAS-mutated patients, there was activity. So this is the Battle 2 trial, and this is my last few slides. This trial just started at MD Anderson, and it's about to open at Yale. And basically, in Battle 2, it's very similar, an umbrella trial where everyone gets a biopsy. But we have learned from the previous trial. Now, anyone who has an EML4 ALK mutation or an EGFR mutation, they're not going to go on the trial. In a CLIA lab, they'll all have this done. They'll go on trials for those specific mutations or in standard of care because we know we have good, effective therapy for them. But for the other 80%, they'll go on Battle 2. And our focus of Battle 2 is KRAS. In the first half of the trial, the only marker we're using is KRAS to assort the patients. We're going to learn in that first half of the trial, and we're going to explore a number of markers, either hypothesis-based or some of the signatures we developed in Battle 1. And then for stage 2, that's where we're going to sit down with a biomarker steering committee with some very clear statistical rules that we've put in place, and that's when we're going to then develop the adaptive randomization for part 2. This was initially developed as part of a PO1. That PO1 was not funded, but it was funded as an RO1 between Yale and MD Anderson, so this is going forward where we have scientific hypothesis in the laboratory moving to the clinic to validate these markers. This slide, we had a recent IOM meeting. We were talking about complexities of the new design of clinical trials. These were all the steps involved in getting Battle 2 going, and I show this here because this is the STO, and we are going to have to improve some of the regulatory hurdles to getting trials like this going, combination drugs, all the CLIA different assays that are needed, but this is now open and accruing. And the team is really a very strong one, and I've been happy to be a part of it. So just to conclude, personalized medicine is here to stay in clinical trials. I think the battle trial is a good example. It does require enormous infrastructure, it is expensive, and it is an academic collaboration. And it really is a new way of doing things at a medical center. You have to recognize your pathologists, your radiologists, all the clinicians who are putting patients on trial. It really was a team effort. And I'll just stop by saying that the future really is unlimited, because now we have samples, and we can use these samples, and we have normal tissue on these patients as well, to really begin to explore for even more novel markers. Thank you.
Thank you, Dr. Herbst. We have time for one question, if anybody has. Yes?
Thanks.
Richard.
Thanks. That was a great talk. Really enjoyed that. Just one thing I wanted to ask you about is the biopsy strategy. I can understand for mutations, it's pretty fine to put a needle in and take some cells out and look for that. But how representative do you think your biopsies are of the tumour as a whole? Because obviously something like VEGF or cyclin could vary on the position within the tumour, if it's hypoxic or it's an invasive edge. So how do you deal with that?
Well, you know, we've taken one variability out of this by getting at least a fresh biopsy in real time. But you're absolutely right. I was trained by Josh Fidler, and I'm very well aware of tumor heterogeneity and metastases versus the primary. There have been some recent studies lately where people have sequenced 6 different areas of a tumor and shown that the sequence is different. So that is an issue. We're actually doing some work now with multiple biopsies from the same patient to actually look at that. But it just gets more and more complex, and that's why in the first battle we showed it was feasible, we could do it, but there are many things that are going to have to be fine-tuned. Hopefully we can get things from the serum someday, from circulating tumor cells, and again, those are selected cells, but perhaps the most aggressive cells and the ones we want to target.
Thank you very much.